Hi there, my name is Cormac Ryan. I'm Professor of Clinical Rehabilitation at Teesside University. I specialise in research into pain management and particularly pain education. I'm interested in both the rehabilitation of people with persistent pain, helping those with persistent pain to manage it better and facilitate recovery, whatever that might look like for that person, but also interested in more upstream rehabilitation and prehabilitation to help prevent people developing persistent pain as well, whether that's working with people who, in a public health way, who don't have persistent pain yet or don't have pain in any way, but it's kind of helping them to understand the condition better, or whether it's people who have acute or short-term pain to help prevent it developing into more persistent pain. That's me and my background. Um, what would I say is persistent pain? Persistent pain is pain that a person has that has lasted for 3 months or more. In its most simple terms, that's what it is. And it can be categorized into two very broad categories. Number one is primary persistent pain, and number two is secondary persistent pain. Primary persistent pain is pain that continues on for no obvious structural reason, nothing that's identifiable on a scan or is clearly the cause of the persistent pain. Um, and that seems slightly kind of odd to many people in that there can be that pain without some obvious structural problem or pathology, but that's kind of just how pain works. Pain can continue long after normal tissue healing has occurred or long after a pathology has resolved. Um, Conditions that would fit that category would be things like non-specific lower back pain, which is what 90% of people with lower back pain are categorized as having pain from back pain in the back for no obvious structural reason. Other conditions would include things like fibromyalgia or complex regional pain syndrome or phantom limb pain. These are all different pain conditions for which there's no obvious structural pathology. Um, the other category then is what they call secondary persistent pain. That's pain for which there would appear to be a underlying structural or pathological cause. This would include conditions such as rheumatoid arthritis, where there's clearly a very inflamed, swollen joint occurring that could be the cause of the pain and um, intuitively seems to map to the amount of pain. These two are not mutually exclusive. Sometimes they overlap. So what I have learned in my 20 odd years in the field is that pain education is really, really important and good at pain education at every different point in the journey. So if we could provide good education before people develop chronic pain, they could better understand the condition. They could, when they come, then if and when they encounter clinicians, their expectations of what they might receive in terms of care might be more aligned with what they actually receive. So guidelines recommend active physical and psychological therapies, such as physical activity and cognitive behavioral strategies. But often when people go in, that's not what they expect to receive because they've got, let's say, a more pathology or structural understanding of persistent pain, that pain is due to tissue damage that needs to be fixed or healed. And so if that's your understanding of pain, then it's often not necessarily aligned with those active physical and psychological therapies. So good education right across the point before people develop pain, um, when they develop pain in the acute stage, and indeed then people with chronic, persistent, long-term pain so that they better understand how to manage that pain. Why is the Northeast, North Cumbria, an outlier in terms of opioids? I think it's very hard to pin it down to one key thing, but I think education is a key factor, both for the general public and patients, so that they can understand uh, um, why these medications aren't particularly helpful and could actually make the situation worse. I think the same applies to healthcare professionals. We need better training and understanding there as well. Um, I think why in the Northeast, perhaps it's partly to do with there being quite a degree of disadvantage in the area, quite a lot of socioeconomic disadvantage, which brings about greater levels of pain and perhaps lower levels of health literacy, understanding our health conditions and how to manage them. Um, but there may also be an element of habit. It's something we've gotten into the habit of doing. Habits are really, really difficult to break.